Greetings and good morning. And it's good to see everyone who's here. And we hope and trust that people are, I can't say too much, but breathing a bit easier today and have enjoyed what took place yesterday in our nation. I certainly was pleased, and I think most of us were. So thank you. Thank you for being here today. And let me announce our upcoming rounds. We have on February 4th, we have two of our own HIV Center affiliates, and that would be, it's a double header with two people in each part. So the first part will be Laurie Bauman and Joanne Mantell, and they'll be talking about barriers and facilitators to PrEP for high-risk adolescents. The new title I was just given, What Do Adolescents Think About PrEP? And the second part of the February 4th presentation, again, HIV Center affiliated people, are Abigail Bam-Lance, formerly from CUNY, now at the Veterans Health Administration, and Rachel Schenkel at CUNY. And they'll be talking about, in the context of COVID, managing older HIV positive adults and comorbidities. And then our second rounds in February will be on the 18th, and that will be external presenter, Laura Bogart from RAND Corporation. And the title for that is Addressing Medical Mistrust and Strengthening Resilience to Intersectional Stigma Among Black and Latinx Sexual Minority Men. So please note those in your calendar, and we look forward to seeing you there. Unless anyone else has any announcements to make.
Bob, I would like to introduce a new associate fellow, Dana Watnick.
Go ahead.
Dana Watnick, she is on the Zoom call, so maybe Dana, you can say a little bit about yourself. So she's a new associate fellow in our training program.
Your hair looks fine.
Teo. Thanks a lot. Yes, I am a new assistant professor at Einstein. I have long worked with folks at the HIV Center, though. It's really good to see you, Bob, in this capacity. I am joining the fellows because they are at a similar stage of work, and most of my research has been around adolescent HIV prevention, but also around sexual and reproductive technologies for prevention of HIV and pregnancy. And I also work at our CFAR in the Behavioral Science Core with Laurie Bauman, doing a lot of qualitative and mixed methods work and cognitive interviewing, et cetera. So it's really great to be here. Thank you so much for including me.
Great, and welcome. And it will be so nice to work with you again, in different capacity. Okay, were there any more announcements, Teo or Stephen? Excuse me.
No. Okay,
so I'll announce our two very special speakers that we have today that we're privileged to have with us today. We have Charles King and Ginny Shubert. Charles King is one of the founders and the CEO of Housing Works, which I think many of you are familiar with. It's a community-based, not-for-profit organization that provides a full range of services, including housing, healthcare, mental health, chemical dependency, legal services, advocacy, job training, and employment for homeless men, women, and children living with HIV, AIDS, and other chronic conditions. Charles has worn many hats. He served on the governing body of UNAIDS as a member of the NGO delegation to the program coordinating board, and was co-chair of the New York State Ending the Epidemic Task Force, which I had the pleasure of working with him on. And Charles is currently a member of the New York State AIDS Advisory Council, and he is the co-chair of the AIDS Advisory Council Ending the Epidemic Subcommittee. Again, a committee on which I have the pleasure of serving under Charles's very strong leadership. He also co-chairs the Act Now End AIDS Coalition, a national ending the epidemic coalition, and serves on the board of the National AIDS Housing Coalition, which has produced 8 research and policy summits to generate research proving the efficacy of housing as an intervention, HIV intervention, and aims to turn the research into policy initiatives. And Charles holds both a law degree and a Master of Divinity from Yale University and is an ordained Baptist minister. And he's very good in that role, I've witnessed. Ginny Shubert, she co-founded and now acts as senior advisor on policy and research for Housing Works, which I just described. She has over 30 years experience as an attorney, advocate, service provider, consultant, and community-based researcher, working on poverty and health issues, including homelessness and access to housing, HIV/AIDS, tuberculosis, and drug user health. She's a graduate of the Harvard Law School and has been counsel in landmark lawsuits involving access to care and services, including federal and state class actions to establish the rights of New Yorkers with HIV to safe, medically appropriate housing, and to reasonable accommodations necessary to ensure access to public entitlements. In 1988, Ms. Shubert founded the AIDS Project of the Coalition for Homeless, and when Housing Works formed in 1990, she established its advocacy and public policy department. For the last 25 years, Ms. Shubert has worked as a consultant on housing, health, and economic justice issues. On a more personal note, I'm very familiar with the work of both of these people, both Charles and Ginny. I have to say that they never cease to amaze me with their brilliance, their creativity, and most importantly, for their remarkable humanity and tireless advocacy. So thank you both for gracing us with your presence today, and I turn it over to you.
Thank you very much, Bob,
Yeah.
and thank you for inviting us to be here and to present today. As Bob described, Housing Works is a New York City community-based organization founded 31 years ago this year as a membership organization of clients, staff, and volunteers. Ginny Shubert is along with me, among the small group of community activists who founded Housing Works in 1990. And as Bob said, she now acts as senior advisor to Housing Works on policy and research. I have to say, Ginny insisted that I be the one to deliver this talk while she managed the slideshow, but I need to acknowledge that over the last several weeks, I've been sending her bits and pieces of script, and she has woven it together into what hopefully is a coherent and compelling narrative. And we very much appreciate the opportunity to present at these grand rounds. So Housing Works came to life as a community response to the inability of people with HIV experiencing homelessness to secure safe, affordable housing. Today, we would like to tell you a little bit about our history and DNA, and then share with you new plans to expand our efforts to more fully realize our stated mission to end homelessness and AIDS by envisioning a radical transformation of homeless services in New York City. Today, in 2021, Housing Works provides comprehensive HIV prevention care and services for over 25,000 individuals annually, with a focus on the most vulnerable and underserved people affected by the AIDS epidemic, those facing challenges of homelessness, mental health issues, substance use disorder, and other chronic conditions and incarceration. In 2019, Housing Works and Bailey House merged, creating one of the largest HIV service organizations in the country. Services including outreach, HIV counseling and testing, case management, roughly 600 units of transitional and permanent supportive housing, and 4 federally qualified community health centers that provide primary care, dental services, behavioral health care, including syringe exchange and other low threshold harm reduction interventions. This includes the first substance use disorder treatment program licensed by the state of New York that uses exclusively a harm reduction modality. These core services are supplemented by extensive peer education, job training and employment, and client legal service programs. In addition to our direct services, Housing Works advocates for evidence-based policy and practice at the local, national, and global levels through offices in New York and Washington, D.C. Housing Works also engages in advocacy and service provision through programs located in Fajardo, Puerto Rico, and Port-au-Prince, Haiti. Our advocacy to this day includes nonviolent civil disobedience and other forms of creative direct action. But to understand the roots of Bailey House and Housing Works, it's necessary to go back to the darkest days of the AIDS pandemic as it wove through the various communities of gay and bisexual men, transgender women, people who injected drugs, and sex workers. In its first 4.5 years, Bailey House, which only has 44 residential rooms, had experienced 230 deaths. Literally, that is an average of a death every single week. When Bailey House opened in 1986, it was the first housing in New York City for homeless people living with AIDS. And I say AIDS deliberately because the city's Human Resources Administration had established its Division of AIDS Services, now called HIV/AIDS Services Administration, or HASA, to prevent homelessness by providing enhanced rental assistance for housed people with AIDS or AIDS-related complex, that is, mild symptoms. But applicants who were homeless had to prove that they had an AIDS diagnosis to get housing assistance. The racism behind this distinction is irrefutable. Even then, the rental assistance offered wasn't usually enough, not to mention the stigma and discrimination, to secure housing on the open market. So when Bailey House opened, there were already thousands of homeless people living with AIDS and HIV in the New York City shelter system. By 1990, when Housing Works was incorporated, nonprofit organizations had fewer than 350 units of supportive housing available for an estimated 10 to 13,000 people with HIV or AIDS experiencing homelessness. To make matters worse, the thinking at the time was that homeless people who experienced substance use disorder couldn't be successfully housed. So for the few units of supportive housing available, applicants had to prove that they not only had AIDS, but that they had been without drugs or alcohol for at least 4 months. And even if the policy had been different, the reality is that AIDS organizations at that time didn't want to deal with homeless people and people who use drugs, often seen as one and the same. And homeless organizations didn't want to deal with people with AIDS and people who use drugs, often also seen as one and the same. The conception of Housing Works came from two sources. One was Ginny, who founded the AIDS Project, as Bob mentioned, at the New York Coalition for the Homeless in 1987, and in 1988 founded a landmark class action lawsuit, Mixon versus Grinker, against the city and the state of New York, that demanded medically appropriate housing for all homeless people living with HIV. The second was a small but hardy group of folk in ACT UP who were concerned about the number of homeless people we saw begging on the streets, identifying themselves on their cardboard signs as people living with AIDS. That group of people decided to form a caucus within ACT UP that called itself the Committee to Demand Housing Now for Homeless People Living with HIV/AIDS. The two then came together. The lawsuit built on New York precedents that had established the right to shelter and the common law duty of care that the shelter provide must be safe and habitable. Ginny won a preliminary injunction on behalf of the named plaintiff, Kenny Mixon, who had been hospitalized 3 times in just 1 year for infections. The court ordered that Kenny be placed in a private room rather than a congregate shelter. But the city refused to make the placement, demanding more and more health information and examinations. So ACT UP's Housing Committee, our abbreviated name, took over the office of William Grinker, then the Human Resources Administration Commissioner, handcuffed themselves to his desk and refused to leave until he gave Kenny a private room. Kenny got his room and a new partnership had been forged. Still, though Kenny had been granted the right to private housing as a result of the lawsuit, no nonprofit provider would accept him due to long-standing and ongoing substance use. He was instead placed in a commercial single occupancy hotel where his illness left him especially vulnerable to violence and theft. Kenny was the first client housed by Housing Works in 1991. Since I was in New Haven attending law school, I wasn't a part of that first action, though I was indeed very active by that point in ACT UP. I came down to the city Thanksgiving evening and slept on a friend's couch so that I wouldn't miss the second action. We painted sheets with messages about homelessness and AIDS and did a sleep-in on Black Friday in the entrance of the shopping area in Trump Tower on Fifth Avenue. At this point, I was already an old hand at civil disobedience. From that arrest, we threw ourselves into creative actions to draw attention to homelessness and HIV. I had written Ginny a note congratulating her on the Mixon preliminary injunction, and we stayed in touch. When I graduated from law school, I inquired about a job, and the next thing you know, I was hired to be Ginny's staff attorney. My main job was providing case management for the dozen or so plaintiffs in Mixon versus Grinker. The rest of the time, I was free to raise hell with ACT UP. I could regale you with stories about our creative actions, including being arrested in a revolving door attached to a toilet, but I'll save those for another time. Between the lawsuit and publicity from our actions, the Koch administration felt pressure to come up with a plan to deal with homeless people with HIV. Literally, the Koch plan was to separate people in mass congregate shelters, sometimes just with a curtain, people with HIV on one side and everyone else on the other. So much for confidentiality. And the violence against people known to have HIV in the shelter system was rampant, not just from residents, but from the shelter staff. We had high hopes for David Dinkins, who endorsed the platform we provided, and then he repudiated it in less than 24 hours after being sworn in. We tried to shame him, bringing in members of the newly formed National Commission on AIDS to tour the Fort Washington Armory shelter in January of 1990. But though it was winter, HRA turned all the homeless men out and cleaned up the place real good. Still, the commissioners were appalled. Then in February, Ginny and collaborating attorneys took the deposition of the then HRA deputy commissioner responsible for the Division of AIDS Services. I remember sitting in the room and being horrified to hear this gay white man, who himself would die of AIDS, testifying under oath that homeless people with HIV and AIDS were all drug addicts or mentally ill, and that they would be better off in the shelter where they would be less of a menace to themselves and others. That night, I went to an ACT UP Housing Committee meeting and relayed what I had witnessed. While we started out the meeting very depressed, I remember startling myself by blurting out this crazy idea that we should start an organization that would house homeless people with HIV who use drugs to prove the city wrong. By the time we ended the meeting, Housing Works had become a real, if nascent, idea. Even Ginny, the most common sense person I know, jumped in without hesitation. That was February. It took months to come up with a mission statement, craft the bylaws, and file for incorporation. Gay Pride 1990, we held our first fundraiser for Housing Works, raising less than $100, selling sodas and bottled water at Pride Fest. We started working on a supportive housing application. And then in September came my first major donor ask of a wealthy guy in legal trouble who was introduced to us by David Fish, an artist friend from ACT UP, who would later die in one of Housing Works' supportive housing units. In one day, I scored two $50,000 gifts and an office for 6 months. I quit my job at the Coalition for the Homeless on October 1st, 1990, and started as Housing Works' first staff person, working on the supportive housing application and writing grant proposals, both things I had never done before. 6 months later, we had hired our first staff and opened our doors to the world with Mixon versus Grinker, now our lawsuit. I want you to know the story because I want you to understand our DNA. In the early years, we truly didn't think we had anything to lose. We just wanted to show the world what could have been done had we lived in a society that cared. And lo and behold, our very presence and our defiant attitude started forcing systems to change. We were also willing to game the system if that's what it took. I told you that homeless people had to have AIDS to get housing rental assistance, but people who were housed could get the benefits with just symptomatic HIV. So we set up our independent living program. We would lease apartments and then do a legal sublet to these folk with a promise in the sublet that they would pay us back for the security deposit and rent. We would then move them in and take them to the Division of AIDS Services with their subleases to show that they were housed. We included utilities in the rent so that the city would have to pay for that as well. We housed several hundred people that way who otherwise would not have been eligible for housing. I also want you to understand that we founded Housing Works not simply to provide housing and services, but to develop evidence-based models of HIV prevention and care to meet the needs of the most marginalized people living with and at risk of HIV, and then to advocate for replication of interventions demonstrated to be feasible and effective. So let me share with you our mission statement. Housing Works is a healing community of people living with and affected by HIV/AIDS. Our mission is to end the dual crises of homelessness and AIDS through relentless advocacy, the provision of life-saving services, and entrepreneurial businesses that sustain our efforts. I most want to break down this idea of a healing community, which I believe is the #1 thing that distinguishes us from similar organizations. In order to heal our community, we determined that Housing Works had to be a membership-driven community in which every stakeholder had ownership and a voice. That is truly how we felt in those early years. Some of us were living with AIDS, including 2 of our co-founders. Others of our early staff experienced substance use disorder. We were affirmatively hiring people who were HIV positive, who experienced substance use disorder, and who had been homeless. Most of us were visibly hurting. And the best way we knew to heal ourselves was to help other people who were hurting at least as much, if not more than us. Now, I know that in the various professional disciplines, there's a lot of talk about boundaries and about being dispassionate in our work. And I'm not trying to cast that away. But what we knew from the beginning was that we were all in this together. Much has happened in the 30 years since we took the leap to create Housing Works. While we ultimately lost Mixon versus Grinker at the New York State Court of Appeals, it took almost 10 years to make its way through the courts. And during that time, we forced the city and state to dramatically expand the number of supportive housing and enhanced rental assistance units available to people with HIV. Building on that success, we forced the prohibition on placing HACA-eligible clients in the congregate shelter system, established minimum standards for HIV housing that includes private sleeping areas and baths, compelled a system that allows people with symptomatic HIV to pre-qualify apartments for enhanced rental assistance, persuaded HACA to require all contracted supportive housing providers to adopt a harm reduction approach, helped pass a law prohibiting source of income discrimination by landlords, achieved a 30% cap on tenant rent contribution, and finally, in 2016, an expansion of HACA and housing eligibility to all low-income New York City residents living with HIV. And of course, all of this has been tied up in an effort Housing Works helped to initiate to end AIDS as an epidemic in New York State. From the beginning, Housing Works has been committed to low threshold harm reduction approaches to housing assistance, where admission and retention to housing is based on behaviors rather than status as a drug user, person with mental illness, or other condition. Residents are held accountable, as we all are, for the behaviors and conditions necessary to live safely with neighbors, are entitled to privacy in their own home, and are encouraged to feel safe to share behavioral health needs or crises without concern about jeopardizing housing security or being required to engage in a particular course of treatment. From an initial 40-unit city-funded housing program in 1990, Housing Works has evolved in response to client needs into a large multi-service organization that offers integrated medical, behavioral health, and supportive services, and almost 600 units of housing, including Housing Works developed congregate community residences that serve people with HIV who often face particular barriers to both the housing market and retention in effective HIV care, including transgender women, LGBT youth and young adults, and women homeless at the point of leaving prison or jail. Among our many innovations are an intensive job training program for people living with HIV that usually places people in permanent employment in Housing Works' own workforce. Over the years, we've been thrilled to help graduates of this program gain successful employment, go back to school, some even getting master's degrees and growing into management roles in our organization. We now offer a less intensive job readiness program for people leaving the city correction system that is showing considerable success that I will reference later. And then there is our Undetectables program, which is a now thoroughly proven intervention tool that includes cash incentives to support viral suppression for people living with HIV who have found treatment adherence to be a challenge. We believe that all persons deserve a safe, comfortable, and welcoming home. These are pictures from our LGBT youth housing, and we're extremely pleased that our supportive harm reduction approach has proven effective in supporting health, with the rate of viral load suppression among residents in our housing programs over 90% over the past 4 years. Then came 2020. As you know, in 2020, we faced another disease for which we had no effective treatment or prevention, one that remains especially dangerous for those vulnerable due to age or underlying health conditions, and one that poses a particular threat to persons experiencing homelessness, whether in congregate shelters where it's easily transmitted or trying to survive on the streets. Sadly, the COVID-19 and HIV epidemics are similar in another way. Like HIV, New York City Department of Health data shows that certain New Yorkers, especially low-income, Hispanic, Latinx, and Black African-American community members, continue to experience a disproportionate burden of COVID disease and deaths. These disparities reflect deep-seated racial and ethnic health inequities that must be addressed, even or perhaps especially while we are in the throes of an unprecedented and frightening public health emergency. New Yorkers experiencing homelessness are at particular risk. Homelessness remains at record levels in New York City. When the COVID crisis began in March, approximately 70,000 persons were sleeping in New York City shelters each night, including over 19,000 single adults in congregate shelters where numerous persons sleep in a single room and share bathrooms and common spaces. Thousands more New Yorkers were struggling to survive on the streets and other places not intended for sleeping, while contending with a drastic reduction in access to food, bathrooms, showers, and other resources typically provided by drop-in centers and other settings that were rapidly closing to them. Not surprisingly, as of the end of October, the New York City Department of Homeless Services, DHS, has tracked 104 deaths from COVID-19 among people experiencing homelessness, including 95 sheltered individuals. An analysis of available data conducted by the Coalition for the Homeless in collaboration with researchers at New York University found that through the end of October, the age-adjusted mortality rate due to COVID-19 among sheltered homeless New Yorkers was 406 deaths per 100,000 people, 70% higher than the overall New York City mortality rate of 231 deaths per 100,000 people. I thought back to 1990, this last March, in a conversation with Steve Banks, New York City's Social Service Commissioner. At the time, the Department of Homeless Services guidance was to screen every shelter residents for COVID-19. Anyone showing symptoms or with rare testing capacity testing positive was to be taken by ambulance to a hospital emergency room to be tested. You will recall at that time, the shortage of tests led to a rule that only people requiring admission received the test. Whether tested or not, unless hospitalized, the homeless person would be discharged to the street and not allowed back into their shelter until they could prove that they were negative to the virus. In plain words, we were forcing people suspected of having COVID-19 into the streets. Housing Works, the Coalition for the Homeless, and other members of the New York Community COVID Working Group forced the city to provide hotel rooms for homeless people in the city shelter system who had or were suspected to have COVID-19. Steve Banks told me he had been given authority to lease as many hotel rooms as he needed for isolation shelters, but that he needed providers to run them and no one was coming forward. I promise you, there was no strategic vision. I had always said Housing Works would never accept a contract from the Department of Homeless Services. But I immediately hearkened back to the time when no one wanted to serve homeless people with HIV, and I blurted out, Housing Works will run one. On March 17th, Housing Works opened a Department of Homeless Services isolation hotel with 170 rooms to provide a safe, private, and supported space for people experiencing homelessness to recover from COVID illness. This is actually a picture of me with other staff wearing generously donated PPE to clean and sanitize rooms in the tourist hotel rented by New York City for use as our isolation shelter. We've served over 500 guests so far, applying lessons learned from years of providing harm reduction housing. I want to comment on our staff at this hotel. In order to provide comprehensive services, in addition to the professional disciplines, we had to hire around 45 residential aides to support our residents, provide escort services, and security. Housing Works does not hire security guards for any of its housing. We had less than a week to hire and train this team. Nearly half of them came from our job readiness program for people leaving corrections. It was pretty much an open hire process. And a third of our staff were themselves living in the shelter system when they started working for us. I was there with them every day for the first 5 weeks, and I will admit that we had to screen out a few characters who weren't really ready for work. But those that survived probation have proved to be some of our most caring and compassionate staff. After much work, most of our homeless employees have now been able to move into permanent housing. And for the rest, we've been able to get them private rooms in hotels rather than staying in congregate shelters. I can't say enough about this workforce, themselves greatly at risk for COVID-19, but stepping forward both because they desperately wanted to work and out of their sense of compassion. Our experience has demonstrated that a true harm reduction approach is critical to successful voluntary isolation, even down to providing unhealthy snacks and cigarettes for smokers so that they don't need to go down the street to the bodega. And that voluntary isolation is critical to successful contact tracing and disease management so that vulnerable people are not afraid to be tested and to share their contacts for purposes of tracing. Private rooms are both humane and necessary, especially for people with mental health issues who cannot manage a shared space with a stranger. On-site medical and behavioral health services are key. Most of our isolation residents show up with multiple chronic conditions that have been untreated or undertreated and presented health issues as serious or more serious than COVID-19 infection. We had insisted on medical and behavioral health staff in our initial contract. After resisting it, DHS came to us in May and asked, would you be willing to provide medical and behavioral health care at our other isolation shelters as well? So we are now providing these services at 6 other DHS and Mayor's Office of Justice hotels. Finally, we've learned that good case management, even during a short 14+ day stay, can be life-altering if we take the opportunity to identify needs and explore options. Sometimes this means refusing to transfer a resident until an appropriate discharge plan is in place. Once we got into this, though, what we came to deeply appreciate is how awful and dehumanizing the city shelter system is. And we started asking ourselves if the coronavirus was providing us with an opportunity to transform the way homeless people are treated in New York City. When the city shut down the subway, displacing scores of homeless people who refused shelter care, we and other advocates demanded action. Again, Steve Banks challenged me. Now we are in the process of opening up a stabilization hotel for people who live on the streets and in our subways. DHS has a search protocol in its shelters to prevent weapons, drugs, and alcohol. As a harm reduction organization, we were adamant that while we would screen for weapons, we would not ban drugs and alcohol, as this would drive people away. A new guidance came out a few months ago, accepting our position. Our executive team met in retreat in August, and we left that meeting committed to a vision of transforming homeless services in New York City. We now see an opportunity in this crisis to transform the way New York City treats homeless people, so Housing Works is all in. Our new homeless programs have a staff that will soon grow to more than 250 employees. Our executive staff and advocacy team are completely focused on this. Is this a shift in our mission? Not really. We realized we didn't need to rewrite our mission statement at all, just realized that we had already committed to ending the crisis of homelessness in our city, independent of the mission of ending the crisis of AIDS. So what is needed to begin to transform New York City's homeless response? Resources, of course, but what is vital are new approaches, a new vision for what is acceptable, and of course, advocacy to build and sustain the political will for systemic change. Sadly, when City Council legislation was proposed in the spring to require that the Department of Homeless Services provide private rooms for all homeless single adults then in shelter, there was strong opposition from existing nonprofit shelter providers who argued that homeless adults would be at risk of overdose or suicide if they were allowed to live in private rooms. We all know that many people experiencing homelessness are in poor health and lack access to accepting, culturally competent medical and behavioral health care. As DHS stated in a 2019 report, those most at risk of homelessness are affected by high rates of poverty, family conflict, and domestic violence, as well as poor health, including high rates of chronic disease and behavioral health diagnoses, coupled with low access to care. Unsheltered people trying to survive on the streets and in the subways and other places not suited for human habitation face even more daunting health challenges and barriers to care. At Housing Works, we formed a visioning committee to research and explore models of support and housing assistance. We are committed, as in all our work, to the meaningful involvement of people experiencing homelessness. Let me share some of our ideas and the stabilization model we hope to open soon in the Midtown Transportation Hub between 34th Street and 42nd Street. Seeing the COVID crisis as a pivotal opportunity for new Medicaid investments to improve health outcomes and reduce costs among homeless persons with chronic medical and behavioral health issues, Housing Works has proposed to New York State 3 potential 1115 waiver applications. The first, comprehensive care for street homeless from street to home, a Medicaid match to existing city and state homeless service dollars that would allow the development and operation of comprehensive care for street homeless. From street to home programs that would combine key elements of existing street-based medicine, drop-in centers, and safe haven programs operating in New York City in a single holistic model that supports street homeless individuals in receiving community-based healthcare and stabilization services required to move them along the housing continuum from street to permanent housing. I'll get back to this model in a moment. Second, medical respite. A Medicaid match to existing city and state homeless service dollars that would allow the development and operation of comprehensive medical respite programs that would provide a safe place for homeless individuals to recuperate following an acute inpatient stay or to recover from medical or behavioral health conditions that cannot be effectively managed in the shelter or on the street, but do not require inpatient hospitalization. And third, medically enriched supportive housing. A Medicaid waiver to create and operate medically enriched supportive housing, MESH programs, to comprehensively meet the needs of homeless individuals with complex health conditions and repeated hospitalizations or stays in medical respite by placing them in supportive housing staffed with a team of integrated healthcare professionals. MESH will address the needs of individuals who need more intensive services than those available in supportive housing, but who do not qualify for assisted living programs or skilled nursing facilities. Even short of a Medicaid waiver, we're excited by the prospect of moving towards value-based reimbursement models that will allow greater flexibility in providing the care, including housing, required to improve health outcomes among people with chronic conditions who are experiencing homelessness. Finally, today, let me tell you a bit about our exciting new pilot program, the one Housing Works hopes to get up and running soon with the support of the Department of Homeless Services, our comprehensive stabilization services pilot. As I've mentioned, in response to the COVID crisis, DHS is funding stabilization hotels for single adults, both to de-densify congregate shelters and for those who sleep on the street because they refuse placement in the city shelter system. However, these stabilization hotels do not receive funding to provide medical or behavioral health care, despite residents' needs for services to address multiple comorbidities. Housing Works is close to finalizing a contract with the Department of Homeless Services to support an integrated stabilization center that combines stabilization hotel beds and a drop-in center with on-site health and supportive services. Located in a hotel in Chelsea, the Stabilization Center will offer primary care and behavioral health services, case management support, housing placement assistance, and navigation and referral services. The contract will also include robust peer support and drive referrals from existing DHS-funded street outreach teams to the Stabilization Center, and to provide linkage and navigation services for Stabilization Center clients to Housing Works clinics and other community-based organizations for ongoing care. The draft workflow describes these interconnected services for unsheltered homeless adults: a low-threshold, person-centered, and trauma-informed drop-in center program, a harm reduction stabilization hotel that will operate 24/7, 365 days of the year, and offer residents private rooms, intensive case management services, and access to on-site medical and behavioral health services, residential, recreational activities, and peer support services at the co-located drop-in center. Peers to support engagement, linkage to care, navigation, and other support services. Linkage to Housing Works Healthcare Center at 37th Street, named for Ginny Shubert, designed as a very low threshold clinic, predominantly serving active substance users, homeless or unstably housed individuals, and individuals with mental health issues, as well as a planned health center at 48th Street to offer comprehensive health services. Intensive case management with individual care plans based on comprehensive assessments to identify medical, behavioral health, and social service needs, and referrals to services offered by a robust and integrated network of other health and social service providers. The overarching goal of the Stabilization Center, like all Housing Works services, is to improve the health and well-being of clients experiencing street homelessness by providing low-threshold services delivered in a respectful manner using a harm reduction approach. We plan to evaluate the pilot rigorously, to continue to build our own competence, to offer effective services, and to provide the evidence necessary to support advocacy for system-wide change. We are exploring opportunities presented to repurpose underutilized hotels and commercial spaces to create affordable housing, including supportive housing programs. We cannot end homelessness in New York unless we address the drivers. We need to start by owning that our current homeless system is as much an expression of systemic racism as our over-policing. And like over-policing, it harms more marginalized people like LGBT people of color more than others. Other drivers include the gross lack of affordable housing, mass incarceration that removes people from the workforce and deprives them of access to low-income housing, and the insistence on treating mental illness and substance use disorder among low-income New Yorkers of color as criminal justice issues rather than public health issues. And we certainly do nothing to help homeless people by warehousing them in mass congregate shelters designed to strip them of their autonomy and even their dignity. In a world grappling with the COVID pandemic and its aftermath, we must insist on policies, investments, and innovation that treat people who find themselves homeless as people worthy of dignity, autonomy, respect, and care. We look forward to working with all of you towards this vision of a transformed New York City homeless response. Thank you.
Thank you so much, Charles. I mean, that is just an incredible story and so important. And so thanks to you and Ginny for everything you do and everything you've done, and for sharing the story with us today. I hope you all can see why I have such tremendous admiration, respect, and love for these two people. So I'm going to turn it over to Stephen Sukumaran to facilitate our Q&A.
Thanks, Bob. And yes, thank you, Charles and Ginny, for such a terrific presentation. And I definitely echo Bob's sentiments. So everyone, if you have a question that you would like to ask Charles or Ginny, you can enter it in the chat, or you can simply unmute yourself and speak up.
Stephen, can I start with a question?
Sure.
Could you just elaborate a little bit, give us some details about the behavioral health services specifically? That, I mean, it's tremendous that you have such comprehensive services, and how this organization grew from, well, you told us about the beginning of it, but you know, like who provides that care? What kind of staffing is there? Is it actually in-house? Just any details you can share about the provision of behavioral health services.
Sure. So under our primary care licensure, our federally qualified health centers are equipped to provide behavioral health treatment. So we have a staff that includes psychiatrists, including a chief psychiatric officer, Dr. Pierre Artie, and they provide a lot of the behavioral health, especially as it involves prescription services. We require that every medical provider within the Housing Works system is certified to prescribe buprenorphine. And so we operate a very large program toward that end. But we also operate 2 licensed OASIS providers, both of which operate on a harm reduction modality. Independent of OASIS, we were funded several years ago to do a pilot program for people who are dependent on crystal meth, using alternative medically assisted treatments that our chief psychiatric officer oversees. And then we hold 2 Office of Mental Health licenses that also provide treatment. Generally, we use that for longer term care. There's a lot of work to qualify somebody for OMH licensed treatment that's very cumbersome, and I'm hoping that this upcoming merger between OASIS and OMH will allow us to introduce the idea of low threshold harm reduction oriented services to OMH. OASIS seems to be far more open to that. And then last but not least, we have an extensive unlicensed harm reduction program that is funded largely through the City Department of Health and Mental Hygiene and the AIDS Institute. That includes syringe exchange out of all of our clinics and 2 major syringe exchange centers, one on the Lower East Side and the other at our West 37th Street location. We are hoping to be one of the pioneers piloting a planned 5 overdose prevention centers that would actually facilitate people being able to inject drugs in a safe and protective environment.
That's fantastic. Thank you, Charles.
Stephen, could I just love to, first of all, this is Pete Gordon, Charles and Ginny, just echo Bob's comments about all the work that you 2 and Housing Work has done in these areas is just incredibly inspiring, and we owe you all a deep debt of gratitude. I guess the 2 questions that I have is how can institutions like NYP and Columbia and other major care providers in New York help specifically with this mission around providing comprehensive services in a dignified manner to the large homeless population in New York. I think, as we all know, we have erected, unfortunately, barriers to accessing so much of this care. And do you have any specific thoughts about what the major medical centers could do to really do something tangible in this area? And then I'd also ask you to maybe say where we are in the safe injection centers that have been, it seems like this has been going on for 2 to 3 years. And I know there's been a lot of barriers that have been erected, but how close are we really to perhaps realizing them becoming operational in the near future?
Well, first of all, I have to start by saying I take the compliment as high praise coming from two of my heroes, both Bob and Pete. But
here.
I also want to go directly to how institutions like Presbyterian and Mount Sinai and others could be involved in this. And I think the first is advocacy. The hospital system in New York has immense influence. City and State just published yesterday their list of 100 power folk in health, and you look at the top and it's all, I think we need to get hospitals to demand some of the changes that we're putting forward in terms of doing a Medicaid waiver that allows the dramatic expansion of services directly out on the street and in the community that would allow us to treat homeless people in a very, very different way than what we do now. And I think now is a real opportunity to push for that. I think we'll see a new CMS director named very soon. I think we can push against this idea that Medicaid dollars can't be used to house people and other things. But we need the power brokers who can persuade our governor that these are effective and cost-effective solutions. The second thing I would say is that, Pete, it would be great at some point for you and Ginny and folk like Sharon Duke to present together on the pilots that we've been working on that really take advantage of electronic medical records and access to those records by both the city social services agency and social service providers, as well as the medical providers, to communicate with each other, identifying people and being able to swiftly find people who've fallen out of care, link people to the care they need. Imagine if we had the kind of medical respite program such that when somebody came into your emergency room who was homeless, didn't really need an admission, but did need a safe, caring place where they could recover from whatever condition. If you could just electronically make a referral happen, have somebody show up with a vehicle, transport them to that respite center without them falling through the cracks or being sent back to shelter care. That's kind of the structure that we envision. And we see you all as critical partners in bringing that kind of structure into reality. As far as the overdose prevention centers, unfortunately in Philadelphia, we had been very optimistic. The U.S. attorney under Trump had filed a civil suit to stop Philadelphia folk from opening up a city-supported overdose prevention center. The local community won at the district court level. It was a great victory. But sadly, notwithstanding what we thought was going to be a favorable outcome, the Third Circuit ruled that the Overdose Prevention Center on a 2-to-1 vote was in violation of the crack house statute. So this, the folk in Philadelphia are discussing whether to go to this Supreme Court. Probably nothing to lose by going there, but whether they go there or not, we probably need a federal legislative fix. And notwithstanding his promises to the contrary, I seriously doubt that our governor is going to have the courage to move forward, particularly after this decision.
Yeah, I was going to agree. I think it's going to require change that federal legislation in order to remove this barrier. Because I don't see our governor having the courage to do that. And I wanted to echo what Charles said. Unfortunately, the Department of Homeless Services has not accepted yet the proposal to consent folks to Rio, to HealthX. And that really is a barrier to their being able to provide effective medical care for the folks in their system. And it's even a barrier to understanding more clearly what the health status is of our homeless population. The only data we have is data that's collected from clients at assessment, so it's self-identified alone. So I would agree. I think that moving into the future with electronic health information would be a great step forward.
Actually, if I could piggyback on that, one thing that providers could be doing that would help us with this, HealthX, which is the largest Rio in the state, has been working on a project for several years now that I know Pete is familiar with, that is trying to identify and flag homeless people and people who are precariously housed in their system. There are various complicated ways to do this, but one of the easiest and best ways is that every time a patient comes into a medical facility, if they were asked for their current address, that allows us to identify people who are unstably housed by moving frequently or are giving an address that we know to be a shelter address. And all too often, providers, and I appreciate it's not the actual doctor or nurse practitioner, it's usually a medical assistant or someone else, just overlook asking that critical question that would really help us identify people.
Thank you both, really. And again, thank you for all the work, and we'll take back the advocacy that you brought up, Charles, and try to see if we can get an audience with some of the leadership at NYP to really push that forward, because I agree, I think really this is the time to do it. And we want to do everything we can to sort of partner with you all and support the work, because it's just tremendous and sorely needed.
Thank you.
Thanks, Pete, for those great questions. Anyone else?
Can I say something, Fran?
Go ahead, Fran.
Charles, hi, how are you? Fran Kunos here. I just wanted to ask you what your views are about taking care of a very discrete population. You know, a lot of what you're doing is for a global population, which is fabulous. But I've done work with the severely mentally ill and the HIV epidemic for a very long time. And it's been very difficult to get good care for them for HIV, because the State Office of Mental Health has never gotten on board for testing or any other piece of this, of how to respond. And I'm just curious, what do you think is going to happen? First of all, do you think there really will be a merger of OASIS and NYS-OMH? Because, you know, attempts have been made before that didn't succeed. And do you see a place where this small subpopulation might fit into the bigger picture?
So first of all, at least as recently as my conversations with folk in leadership in October, I do think that the merger is going to go through this time. I think OMH will be the lead entity that OASIS gets folded into, but I'm hoping it will be a case of the tail wagging the dog. If that happens, I think part of the incentive for making it happen right now is just the financial realities that the state is facing. Having two duplicate systems is very costly, and bringing them together would yield considerable savings. But here's what I would say about this, and this is why I'm optimistic about the tail wagging the dog. Under the leadership of folk like Rob Kent, I'm blanking on his name, but the new medical director at OASIS, OASIS has been increasingly, notwithstanding as commissioner, much more supportive of, first of all, of harm reduction. They completely rewrote their regs a year and a half ago to eliminate the term abstinence. So you will not find the word abstinence in the OASIS regs. They have also been much more friendly to HIV testing within their licensed facilities, and looking to provide quality HIV care in their licensed facilities. And so I am hoping that we can leverage that influence to spill over into OMH, where I've often been told very dismissively, yes, we recognize that some of your population is our population, but they're just such a small subset. And that really has been the dismissive attitude in OMH that I think has left people with HIV who face serious and persistent mental illness without the right kind of support to manage multiple comorbid conditions.
Thank you. Maybe this is a great time to try to change it. Thank you.
Absolutely.
And I was just going to agree, there's so much room for improvement, even improving continuity of care as people with HIV move in and out of psychiatric facilities. My understanding is that it just doesn't happen.
Yeah, one of the things that we discovered in trying to look into this with the Planning Council for Part A in New York City was that many people with HIV, when they get admitted to psychiatric facilities, experience a treatment interruption. Now, I don't have data, to back this up, but their HIV medications are discontinued. Or if they've fallen out of care, there's no obligation to reconnect them to HIV care. So I think there's some practices taking place that are really, again, for this very small but very vulnerable subpopulation, extremely suboptimal.
So I would actually comment that I think both city corrections and state corrections do a far better job than the Office of Mental Health, ensuring that people continue on their medications. And we found that not only with HIV, but particularly continuity with hepatitis C, than what happens in the psychiatric institutions. And I think that's the sort of hidebound attitudes that we need to focus on changing within OMH. And I believe if this merger goes forward, it provides us with an opening to begin to do that.
Thank you, because anything you do for that population, I personally will be so appreciative.
Surely.
Thanks, Fran. Any other questions? Feel free to unmute yourself.
Hi, this is Angela Idella. Hi, Ginny. Hi, Charles.
Hi,
and again,
Hi,
I don't mean to take away from discussing the really key issues about services and how they happen. But I also know that you guys have been really out there in terms of doing good research on your initiatives and programs, and that has been integral to kind of like making the case in court and otherwise. So I was wondering if you could say a little bit about your efforts. You had talked about rigorously evaluating some of these new things. Could you say a little bit about your approach toward that?
This is totally Ginny's bailiwick.
Well, that's part of it.
Actually, we're We're just in the process of developing an evaluation plan with some external collaborators, but we have requested funding for that as part of the city contract because this is a pilot. And so far, that funding hasn't been struck out of the budget, so we're hopeful.
Yeah.
But you know, we're in the process, which all of you understand better than I do, of identifying the outcomes of interest. And we also are really intent on using an implementation science approach, because we have so much to learn about how the intervention gets implemented, and to share with others what we learn through our mistakes. So I'm sorry I can't offer more at this point, but we're writing up an evaluation plan.
You can also, I also want to give a shout out to the work that Ginny and Charles have done in terms of visioning, including research and the housing, you know, the HIV and housing research summits, and all the work that's been done along the way to really kind of both help other advance the issue, generate evidence from provider and community sources that have made a difference in changing some of the, you know, some of the policy barriers. So.
Well,
Yeah,
and
one
Angela,
thing that-
yourself have been at the forefront of that, and it's kind of
facilitator. You guys bring the content.
It's kind of interesting because Housing Resources is doing some technical assistance around the various federal EHE plans, and there are a number of jurisdictions that are interested in housing, and they need a lot of help. I mean, some things as basic as planning on only housing those people that have a detectable viral load, just really, you know, nutty ideas. So all of that research is going to be very helpful in these efforts.
And I just want to say, first of all, for all of our research summits, Angela has been on the planning committee, and in fact, she is the one who met with Gina Kwiatkowski and I in a diner many years ago to map out the very first one. The National AIDS Housing Coalition kind of went through a dark spell for a bit, but stay tuned, because we're planning to revive the Research and Policy Summit again in the next year or so.
One of my best, just really quickly, one of my most favorite experiences is working with clients, persons, community folks with HIV who are homeless adult, and explaining how to understand, how to use, how to argue on the basis of adjusted odds ratios. So, you know, I got a lot of you know, teach, you know, you know, more than most of my teaching and research experience. That was the greatest, one of the greatest conference experiences of all. So.
Absolutely. Thank you for that.
Are you working with Dennis at all? Ginny?
Not currently, no, not on anything currently. I've seen some of his recent stuff around COVID. And one of the only, I think, one article that was cited in our presentation, he was a co-author. That was a 2009 study of people street homeless in Manhattan.
Because I mean, I think the city now has a kind of an advocate that's open to using the kind of administrative data matches for some. That's not the same. I'm a believer you got to talk to people directly, but the administrative data matches are also useful and convincing to policymakers.
Can I make one more comment about the OMH system?
Go ahead, Fran.
You know, one of the reasons why OMH can rightfully say that their people are such a small part of the population is because they've been driven out of the OMH system. What's happened is that as soon as you get HIV, you can't really get care in the OMH system. So you wind up going into the HIV care system. I've been to places where it's just amazing the number of people with severe mental illness. I've gone to AIDS day programs where 40% of people were on antipsychotic medication, whether that's what they needed or not. So once you refuse to take care of people with HIV, you push them into the HIV care system. You know, I haven't personally tracked this, but just because I give hundreds, if not thousands of talks on this topic, I've gone to so many sites. And I just want to point out, you know, I don't know how to document it, but by refusing to take care of HIV, if you have severe mental illness, you really need to go into the HIV care system. You can't stay in OMH.
That has been the history, and I can tell you, we have repeatedly knocked up against that wall, proposing to OMH supportive housing for people with serious mental illness who also have HIV. And we've been rejected every time we knocked on that.
We're doing some advocacy work through Part A. Karen
Okay.
McKinnon is also on this call, and Dario. We're doing advocacy work with the Part A Planning Council. They're going to call OMH into it. And if there's some way to create pressure to make them do something after all these many, many years, you know, that would be great.
We'd be happy to be a part of that advocacy.
Great to see partnerships established during the Q&A.
For your very eyes. This is Karen. This is a kind of separate issue from what Fran was just mentioning. You guys have been brilliant at, you know, identifying gaps and bridging them to the extent possible. But we have a new administration now, and I just wonder, you know, what are the opportunities for us to stop pretending that there is a system of care in this country? I mean, it seems like so much of the problem that you all have been working on forever really has so much to do with how we not only disenfranchise people from care, but just how we don't even pay attention to, you know, whole people in terms of their needs in our healthcare delivery. I won't call it a system, and I know Dario would back me up on this. So I'm just wondering if you could make some recommendations that we could all sort of join in together to the new administration about how to create an actual healthcare system in this country. What would that look like?
So I think there's some starting points. Not to get to what the ultimate would look like. I'll get to that in a bit, but I think there's two starting points. One is there are far many people in this country that do not have health insurance, period. Really pressing the Biden administration to be as expansive as possible in broadening. You know, he's not going to do Medicare for all, but he has proposed legislation that would expand the Affordable Care Act dramatically, and hopefully would entice states that haven't expanded Medicaid to do so. And I think that's a very important first step. And then, you know, if he really were to follow that, and I don't see that until the midterms and, you know, more Democratic control in both the Senate and the House, to be able to achieve at least an opt-in Medicare program. I think that's the second thing that's important. We've been a part of a national working group that's been meeting for several months and has been meeting with the transition team to promote harm reduction approaches to everything this administration does. And I think that's very important to pull people with substance use disorder in care. I mean, there is a reality that something like 80–90% of people who have who are experiencing substance use disorder never get treatment, and they're not going to go into our existing treatment models. And so I think that is a very big step. But I also want to, so going to your final, what would it look like? We really need transformative action at the state level. And I'll go back to something that I mentioned in response to a question by Pete Gordon. We have a system in New York where particularly the teaching hospitals have an extraordinary amount of control over the healthcare dollars. In fact, it's not just the teaching hospitals, it's a relationship between the teaching hospitals and 1199, to be honest, that tremendously influenced those dollars. And that has made it very difficult to create community-based systems of care that are comprehensive and can then link into the hospital systems when that kind of care is needed. And I think that we really need to completely rethink that whole relationship. Right now, if you look at what is most under strain and most under threat by our governor, it's the safety net providers. That's just because the safety net providers don't have nearly the same influence at the table as Greater New York or 1199 or Haney's. And I think that there needs to be a different kind of conversation, that this shouldn't be about just protecting particular types of institutions. This should be about creating a true system of care that serves everyone.
Thank you.
Probably my most political statement of the day.
No, it's so helpful to have that big picture because we come at it in our own tiny little siloed ways. So thank you for that.
Sure. I would throw in one other in this, since you got me started on this rant, and that is the insurance companies. And I'm talking about, in particular, the Medicaid insurance companies, but I would say the same thing for the privates. When Jason Helgerson was our Medicaid director, he came forward with some really innovative ideas, and I didn't agree with every single one, but I agreed with a whole lot of them. And one of the things that I really supported, and I'm still technically on the work group, is value-based payment. And the insurance companies have done everything in their power to undermine the possibility of a true value-based payment system happening in Medicaid, which I think does a tremendous disservice to consumers who are currently receiving completely disjointed care, where everybody's getting paid fee for service. And frankly, it incentivizes the wrong kinds of care, more care than is needed for some, and less care that is needed for others. And they're a powerful force that needs to come around to thinking differently as well.
Thanks, Charles. Any final questions? If not, I'll turn it over to Bob for closing remarks.
Okay. Well, I can only repeat our gratitude for you, as I said, gracing us with your presence. It's been a privilege. And yes, as Stephen commented, it's good to see that, I know there are already a lot of connections, with you all and people on this, but, maybe strengthening those connections and advocacy and developing some new ones. So thank you both so much. I mean, it's just so important and tremendous. And we just really value and appreciate what you do and who you are. So
thank you, Bob. And I see Ginny put her email in the chat. I wasn't thoughtful enough to do that. So please feel free to share my email with the folk who are attending.
Okay.
Happy to keep the conversation going.
Thank you both for that.
It's pretty simple. It's king@housingworks.org. Okay.
And he is.
Thank you so much for this opportunity.
Thank you all. And we hope to see everyone on February 4th for our next HIV Center rounds. Take care, everyone.
Good to see all of you.
Bye-bye.